Well, welcome to our virtual event discussing superior facet joint violation. I'll start by saying we're humbled by the presence of our two speakers, Dr. Thomas Mroz and Dr. Reginald Davis. So in the interest of time, I'm going to introduce both of them now and then cover a few housekeeping items. Dr. Mroz is the director of the Center for Spine Health and director of spine research at Cleveland Clinic. He's a board-certified spine surgeon in the departments of orthopedic surgery, neurological surgery, and the Center for Spine Health at Cleveland Clinic. Dr. Mroz specializes in all aspects of spine surgery. He has a dedicated interest in minimally invasive and cervical spine surgery. He's very active in research and has lectured nationally and internationally on minimally invasive and cervical spine surgery. He's authored numerous research articles, textbook chapters, and serves as a reviewer for several peer-reviewed publications. He's a member in good standing with NASS, AAOS, and is a diplomat of the American Board of Orthopedic Surgery. He continues to have a very active role in the education of medical students, residents, and fellows. Dr. Davis is a board-certified neurosurgeon specializing in minimally invasive spine surgery. He graduated from Johns Hopkins School of Medicine, where he completed an internship and residency in general surgery, followed by a neurosurgery residency. He went on to complete a research fellowship with Johns Hopkins, and he holds a part-time faculty position there to this day. During his active tenure in Baltimore, he was affiliated with multiple institutions and served as chief of neurosurgery for Baltimore Medical Center. He also actively participated in clinical research projects, including post-market studies and investigational device trials. He's an active member of many medical organizations, including the American Board of Neurologic Surgery, American Board of Spine Surgery, CNS, AANS, and a fellow of the ACS. He currently divides his time between clinical care in Florida at the Biospine Institute and his ongoing affiliations in Baltimore. Without further ado, it's my privilege to present Dr. Thomas Mroz.
Thank you, Kim. Kim, can you see, you're seeing my slides okay?
You're good.
Good. Well, welcome everybody. It's certainly a pleasure to be providing this talk today. I was approached by Wenzel Spine to give a talk on lumbar facet joint violations, and in particular, superior joint violations. We had done some research at the Cleveland Clinic regarding this, and so we have some, I wouldn't call it expertise. We certainly have some expertise in violating joints, but I think we have some expertise in trying to understand why they happen, how they occur, and how we can potentially mitigate them. Okay, there we go. So just as a background with regard to fusion surgery, and this is from Becker in 2019, we don't have great data in terms of how many fusions are performed annually in the United States, but we know that 1.6 million instrumented fusions occur annually, including cervical, thoracic, and lumbar spine in this country per year. We think that there's roughly about 350,000 lumbar interbody fusions that are performed annually. I would suspect that the number of instrumented lumbar fusions is probably in the range of about 500,000 per year. But again, we don't have hard data on this. A lot of the data that we do have comes from large data pools, but aren't necessarily exclusive to or inclusive of every parts of the population. Now, facet joint violations come in many varieties, and the literature has been done a pretty good job over the past 10 years or so in trying to grade the types of violations. What we don't have now is a good bulk of literature that clearly defines what type of violation is going to give you each specific outcome and how it's going to subtract from how a patient perceives their outcome in a variety of different time points. Obviously, there are a ton of different variables that go into this equation, everything ranging from the patient to the patient's own anatomy to the patient's sagittal anatomy, et cetera. And so I don't know if we'll ever have that data, but we do have some good data to suggest that, in fact, when we do violate the joints at the superior unfused levels, it does have a pretty bad outcome with regard to the patient. And this is just an example showing two different patients. And this is an example up on the left-hand side where the joint on the patient's right, again, looking at the left panel, but on the right side of the patient, the tulip of the pedicle is roughly in the right spot. You want to be at the junction of the transverse process and facet when you're inserting your pedicle. However, on the patient's left, again, looking at the left image, we see that it starts to abut the facet the lateral border of the facet joint, which is in part a facet joint violation. Whereas you go over onto the right side, the right image, you can see that the screws are in fact going right through the joint themselves. And this is something that unfortunately we see, I wouldn't say I see it every week, but I see it enough times. And not only does it, have an impact on the patient, but it has an impact on diagnosing a patient who has this in conjunction with perhaps a couple of different pathologies that you're trying to diagnostically figure out where the patient's pain is coming from. Because typically when you have a facet joint violation, it doesn't necessarily mean that the patient's going to present with overt instability. However, they do oftentimes have a variety of types of mechanical type of lower back pain that potentially could be related to the facet joint violation. But I think in a quick summary, when we looked at the bulk of the literature on this, we know that rostral facet joint violations pose real risk. We know that there are higher rates of adjacent segment degeneration and disease. We've seen that in our own patient population. There's lower quality of life outcomes, which I'll show in a few moments. There's higher pain scores. There's higher rates of resource utilization, how many times a patient comes back for imaging, whether it's x-rays, CT scans, CT myograms, MRIs, physical therapy, facet joint injections, all types of things that in total put spine squarely in the crosshairs of payers. But also, if you just think about our mission to improve patient care, it subtracts from that very mission of what we're trying to achieve every day. And finally, it oftentimes will result in more revision surgery, which I'll show momentarily. Now, the reasons for facet joint violation at the unfused level, at the cranial aspect of a construct, really comes down to surgeon error. I put it as 1, 2, 3 because really, I mean, these things are avoidable, and it really depends on a lot of factors. A surgeon's perception of what they're seeing in real time, a surgeon's own ability to reconcile what they're seeing with their own clinical surgical skill set. And it also has to do with a lot of other things. How big the incision is, what's the depth of the patient, can you truly get lateral enough, are you limiting yourself? And so there's a lot of different reasons why a surgeon could be off. But at the end of the day, items 1, 2, and 3, it really comes down to surgeon error. This is just one study, and I'm going to go through several different studies that basically summarize the previous couple of slides in terms of what a patient can count on if you violate the cranial facet. This came out of Dr. Park's work. This was looking at cranial facet joint violations by percutaneously placed pedicle screws adjacent to a minimally invasive fusion. And this was retrospective, 92 patients, 184 cranial levels, including 92 patients. These were fluoro-assisted. And so they were using a fluoro-assist and both the AP and lateral plane to help them guide their approach. And what they showed is that there were 50% of patients had violations, again, at the unfused levels, and 31 of these joints were in fact violated. And so these, in the images there show from that paper, just a couple of examples of how that occurs, but this is in line with the images that I showed you before. Yet another study by a different group looked at rates of upper facet joint violation on MIS perc screws and compared to an open instrumentation. This was a comparative cohort study. And what they found is that looking at robotic surgery, it had the least amount of facet joint violations at 7%, 8% for the open group. And believe it or not, fluoroscopically assisted percutaneously placed pedicle screws had the higher incidence. And you would ask yourself, well, why would that be? And I think part of the reason is there's differences in techniques in terms of how the AP and lateral fluoro is utilized. When I used to place these with fluoroscopic guidance, I would have an AP in one plane at the same time. And so if you're going between AP and lateral, it introduces the possibility that you're going to make a mistake with regard to your placement as a potential reason. This is another example looking at the comparison of rostral facet joint violations between robot-assisted percutaneous pedicle screw placement and conventional open fluoro-assisted. And again, looking at 50 patients in each group. And what they found was that in the robot-assisted group, there was a substantially less rate of facet joint violations compared to fluoro-assisted. And so I guess what these papers show is that, number one, these things are occurring. It seems to occur more commonly with fluoro-assisted percutaneously placed pedicle screws, but it is a common occurrence. And if you look at the literature, there are a lot of publications indicating that this is probably an underreported phenomenon. And I think everybody on the call, speaking to the surgeons, we probably have seen this in our own practice, whether we made a mistake ourselves or whether or not a patient was referred to us for the same problem. This is another retrospective study looking at 240 patients that we did. And the whole goal of this study was to figure out whether or not these types of facet joint violations had any impact on the quality of life and other outcomes that a patient would perceive at a 1 and 2 year follow-up. And what we found was that looking at the 1 year follow-up, the quality of life image metrics that we looked at didn't show any difference between those that had violations and those that did not have violations. However, at the 2 year follow-up, we found that the EQ-5D, which is one of the validated functional outcome measures for spinal surgery and other types of care, demonstrated that there were in fact differences that were far in favor of patients not having a facet joint violation. So in other words, patients who had facet joint violations perceived their outcome to be inferior when we appropriately matched the patients according to comorbidities, the surgeries performed, et cetera. We also then looked at the reoperation rates between those that did and did not have facet joint violations. And what we found was that there was roughly a 2 year, again, looking at the second row down here, there's roughly 2 times the rate of reoperations in patients who had facet joint violations, a variety of different grades. And so what we found through an independent or a risk analysis is that facet joint violation was indeed an independent predictor for reoperation and the decreased quality of life in our cohort of patients. And this is somewhat intuitive. It clearly matched, I think, what we were seeing for years in patients that were sent to us, but this was just an example of a study that was done specifically looking at the quality of life one can expect after this type of violation. This is another example of a patient of a group that looked at MIS versus open TLIP surgery. They included 225 patients, 450 cranial screws. Again, 1-level TLIP, open versus MIS. And they got CT scans postoperatively to evaluate iatrogenic facet joint violations. And the picture there just shows the manner in which they did it. They broke it up into quadrants. They measured the facet joint angle. And what they found after a careful grading system that they use an independent grader for these types of facet joint violations was kind of an important finding. They found that the MIS surgeons had a higher incidence that was statistically significant compared to open surgery, 41 to 30%. There was a higher incidence of high-grade violations in the MIS group. Again, I think this speaks probably to surgeons just not picking the right starting points or misinterpreting what they're seeing on the imaging. I remember seeing a video that was promoted by one of our major spine companies in North America for percutaneously placed pedicle screws. And the image literally showed the surgeon in the unfused segment going right through the joint to place the screw. But that was probably 12 years ago now. I think we've come a fairly long way, but nonetheless, I think it still occurs on a reasonable basis. We then did this particular group then did a bivariate analysis and found that patients less than 60 obese, placement at L4 for some reason, right-sided screws versus left-sided screws had a higher incidence of facet joint violations, and patients who had a large body habitus. Again, going to my point of the depth of the wound, making sure that your incision, if you're going to do it through an open approach, is long enough so it doesn't put your approach too vertical, is also an independent risk factor. So in summary, facet joint violations occur at unacceptably high rates. This is clearly an avoidable phenomenon, and I think it really it speaks to the need for us to not only understand the anatomy, but also to be able to translate what we're doing in the operating to our understanding of the anatomy and to what we're seeing in real time, whether it's through an MIS approach or through an open approach, and whether we're using freehand technique or fluoroscopically assisted surgery. And I think the literature has been pretty clear in terms of what it results in if you violate the superior facet joint. That includes adjacent level degeneration, higher reoperation rates, lower quality of life outcomes, and higher costs for the patient in terms of resource utilization post point of care. And that is all that I have. I'm happy to take any of your questions at the appropriate time. Thank you very much. I'm going to stop sharing my screen so my colleague can go ahead with his talk. Thank you.
So you've heard, well, first of all, these are my disclosures. recent consulting for this for the purpose of this presentation, but nothing else of significance. You just heard that the violation of the superior facet joint is a probably underreported, but a significant, potentially significant problem in spine surgery, especially with instrumental MIS. You've heard that the freehand MIS approach, even when fluoro assisted, can lead up to 41% of the total top screws invading that space. Adding fluoroscopy, depending on the specifics, whether it's open with observation or assisted with mini open, the rate is about 9.5 to 32%, still pretty significant. There are ways to mitigate. OR navigation does decrease this rate down to about 8.3. The standalone interbody does represent one way of eliminating the risk of facet joint violation in its entirety. In addition, has the advantages of reduce the need for intraoperative monitoring and overall reduce costs compared to the robotics and navigation, which do incur a substantial increased cost for instrumentation and utilization of disposables. And it does not subject the patient to pedicle screws overall. So again, a total mitigation. There are multiple standalone interbody options. We're familiar with most. There is the anterior approach. This has the advantage of giving a very large graft, total access to the entirety of the disc space with excellent anterior column support and reconstruction. You do not have the ability to really decompress the posterior spine, however, so the decompression itself is an indirect manner. Furthermore, there is a learning curve unless you're really adept at navigating the anterior spine. Having a surgeon, access surgeon, does become important. So there is this learning curve, and subsequently there may be some additional factors that go involved with this. The lateral approach is another fairly recent addition to interbody access. Again, this is laterally access through the lateral aspect, through the psoas in many instances, which in of itself creates some difficulties. Once again, you get a large graft, you have a wide access to the interdiscal space. With proper manipulation, you can get tremendous reduction of sagittal abnormalities and restoring sagittal balance. But once again, the decompression is indirect and the learning curve can be steep. The instrumentation and subsequent to IOM does add additional cost and expertise required. The posterior approach has its advantages. It is direct to the pathology, especially when we're dealing with posteriorly situated decompression or compression, and thereby you get direct decompression. Perhaps the more importantly is familiar to all surgeons. We all approach things posteriorly. We all know, have our special approaches and can adapt accordingly. So this familiarity really mitigates the learning curve substantially, and it really becomes just becoming familiar with the instrumentation itself. The VeraLift LX device is the only FDA-cleared standalone expandable interbody fusion device for the posterior approach. It's intended for standalone use in 1 or 2 contiguous levels in treatment of degenerative disc disease with up to a grade 1 spondylolisthesis, usually of a non-lytic nature, of a degenerative nature. This allows the surgeon to treat each patient with the optimum amount of hardware necessary, and it really promotes maintenance of the healthy muscular and skeletal tissue. Supportive tissues are left pretty much intact, so it tends to avoid further destabilization, but to the point of this evening's talk, absolutely avoids the propensity or possibility of posterior facet joint invasion. The overview is pretty straightforward for the most part. Here's this device. It is expandable. And in doing so, it changes the shape of the footprint, maximizing surface contact to reduce subsidence risk. It really expands some 5 millimeters in 3 planes and increases the lordotic angle. So it goes from 9 degrees to 8 degrees, up to 9 to 8 degrees from 0. You get immediate stability. The threads engage the end plates, the buttress threads resist migration, and you get the really secure fixation anteriorly in the apophyseal ring. So it's a very strong part of the spine. And this results in long-term stability. The large fenestrations and in situ graft loading allow for a tremendous amount of bone to be in contact with multiple surfaces. And the titanium material meets the demands of biomechanical loading, and it's also very, very biocompatible with ongoing fusion. The instrumentation set is very compact and very efficient in its packaging, and really contains all the things that you would need for both assisting with disc space preparation as well as safe implantation with circular neurological guides and all the instruments you need to safely implant the device once the disc space has been prepared without the trauma to neural structures. There are a variety of surgical approaches that are available as this is an implant that allows the surgeon's choice, whether it's going to be open, mini open, tubular, minimally invasive, or even an ambulatory surgery center. All these are at the discretion and available to the surgeon in accordance with the surgeon's expertise and preferences. The device is versatile. It's used either as standalone, as indicated, or it can be used with posterior fixation as deemed appropriate with either screws or with interspinous process stabilization devices. In the standalone application, the disc space preparation is key. Meticulous and thorough evacuation is needed, and preservation of the implants becomes paramount to prevent subsidence and to prevent device migration. The surgical steps really start after the surgeon has exposed and approached the spine in a manner in which you're most comfortable for the given patient, and then the disc has been evacuated and properly prepared. At that point, the trialing step can begin. There are several trials which can be the usual paddle type distractors. Some go in with rotation, others just slide in. Once you've analyzed the overall height of the trial needed, this trial will allow then for insertion. The trial itself is threaded, and so it creates the beginnings of grooves in the spine, which allows the device to follow this. So the step 2, insertion of the device itself, it goes in its contracted condition, but requires no impaction. And so simple, gentle rotation allows the device to be inserted in the least traumatic fashion. And then once properly in place and placed anteriorly engaging the anterior apophyseal ring, it's expanded. And with that expansion, the lordosis is created. There's additional engagement of that apophyseal ring anteriorly, but throughout the end plate, and then allowing this tremendous space. The graft is delivered through the implant itself once it's inside the space. Once that's accomplished, the end cap is placed to secure the bone. The loading device and retractors are removed, and basically it's closed per routine. The post-op protocol is likewise at the discretion of the surgeon. We all have our own protocols, and here's one such protocol that is not at all unreasonable for this device. 6 weeks of restricted activity. Obviously, the patient will be wearing the brace, advised to try and avoid heavy lifting, bending, twisting, or unnecessary bending, lifting, twisting. This can be prescribed for 6 weeks or even some 12 weeks in some cases where you feel that's necessary. It's always a 24 to 40-hour visit, or in the ambulatory setting, a televisit would be more than appropriate just to check on the patient. 2 weeks is the usual wound check, good well-patient check, see how things are going. Typically, x-rays can be obtained just to make sure that there's been no migration, no early changes in stability. And after 6 weeks, the brace is weaned. And after 12 weeks, x-rays secure or demonstrate security of the device. Physical therapy is started and resumption of normal activity as the patient is indicated. Here are just some stock images of some cases that have been performed. This is a 47-year-old gentleman, non-smoker. As you can see, there's a significant degenerative disease at L4-5 with a grade 1 spondylolisthesis that really doesn't change much on flexion extension, so-called sticky spondy, but of a degenerative nature indicative of a degenerated disc. There's also a recurrent disc herniation associated with this, all contributing to fairly severe stenosis. The pre-op VAS was 10, with low back pain, groin pain, as well as pain in left thigh pain and some left thigh radiculopathy. The patient received the device through a TLIF standalone. This was done in an outpatient in an ambulatory setting. The operative time was about 2 hours, estimated blood loss less than 50. No immediate surgical complications were noted. There was reported mild back pain with slight numbness to the left thigh, which again correlated to the radiculopathy seen pre-op, and the VAS score was about 5. Just discharged home after procedure with narcotic pain medication, and a 6-month follow-up. The fusion was fairly solid, or there was certainly stability demonstrated through range of motion. VAS pain scale was 3. The numbness of the thigh was resolving, and now intermittent, only with excessive ambulation. Here's another case. This is a gentleman who experienced a fall, had been diagnosed with severe DDD from L1 through L3. 2 years later, underwent fusion from L3 to S1. 5 years after that, reported back and radicular left leg pain that progressed from medium to severe over the past 12 months. The surgical intervention in this case was a VeraLift placed at the L2-3 of the superadjacent degenerative segment, which, as you can see, the degenerative retrolisthesis, sclerotic end plates, and indication of adjacent segment degeneration. Here are the 6-week, 6-month, and 1-year post-op studies showing progression of the healing with maybe a tad subsidence or remodeling into the end plates, but overall maintenance of stability, maintenance of the sagittal alignment, and maintenance of lordosis that was achieved. Overall, in general, looking at the data available, over 18,000 implants have been utilized in the United States. There's a lot of data, and I'll go over some of the peer-reviewed publications. Overall, the IDE data, the randomized controlled trial, 52 patients were randomized to the VeraLift. And here in general, after 2 years, there was 94% with trabecular bridging bone indicative of solid fusion. 13.4 was the average disc height, posterior disc height being 9.2, which really is indicative of ongoing maintenance of lordosis and significant improvement in the ODIs. A composite of 7 peer-reviewed VeraLift publications are also indicated on the slide. The overall sample size was 855. 611 were 1-level standalone, 237 were 2-level standalone. Follow-up duration was anywhere from 9 months to 5 years, and the mean fusion proportion ranges from 92.3 to 100%, with overall 94.5% fusion reported. Several such studies can be broken out. This is from ATIA, presented at the International Symposium Swiss Spine Institute in June of 2002. A total of 131 standalone patients. There were 26 with pedicle screws and VeraLift. Had undergone 123 1-level and 34 2-level fusions. Radiographic follow-up at 1 to 5 years demonstrated a 95% overall fusion versus a 1.3% revision rate. Here's another study with Doria and et al. Published in the Journal of Orthopedic Traumatology. This is an instrumented posterior fusion and degenerative multi-operated spine. Again, a total of 37 patients, 30 were standalone, 7 did include pedicle screws. Radiographic follow-up at 3 years demonstrated 100% fusion with significant raised criteria of bridging bone and lack of subsidence or lack of migration. Dr. Neely presented data in the International Journal of Spine Surgery 2016. Again, 470 patients overall, 298 1-level, 172 2-level fusions. Follow-up from 9 months on from that point, 94% of patients were found to be fused. 18 patients, or 4%, did require reoperation. 16 for adjacent segment degeneration, 1 at the index level for worsening symptoms after fall, and 1 for a deep wound infection. And subsidence of greater than 3 millimeters was found in 2% of the levels treated. Another study looking at 25% standalone fusions, 18 1-level, 7 2-level. Again, radiographic follow-up was at 12 months and 92.3% fusion with no revisions in this particular study. And this is a study looking at in the Journal of Spine by Wofield et al. Looked at 9 standalone patients, but these were treated for symptomatic adjacent segment degeneration at 1 level. A radiographic follow-up for 24 months. Fusion was at 346 days, average 100%. significant improvement in VAS, went from 9.3 to 2.4. So these studies do indicate the clinical efficacy and overall safety and maintenance and durability of the implant. This is a typical image that can be seen post-op surgery at 6 months. So the image does demonstrate the lordosis, the expansion, the engagement of the implants, and overall stability of the implant at 6 months. Here are some typical post-op images looking at 1 year follow-up, and where again, stability, maintenance of lordosis, lack of subsidence is clearly demonstrated with the device in a standalone fashion. And the CT scan clearly demonstrating a bridging bone between the vertebral bodies through the implant itself. So at this point, I would be in a position to take questions as well, along with Dr. Mroz. I thank you for your time and attention.
Well, thank you both. Do we have any audience questions?
Well, I have one for Dr. Mroz. Do you think that, and I was going to say you have to unmute, do you think that we need to change our approach or our training to mitigate this, or is it just a matter of awareness? That's a big problem that really isn't discussed very much, and it seems like we should be better.
Yeah, it's interesting. I'm older now, so when I trained, we did not use fluoro, and we didn't use robots, and we didn't use CT-based navigation, and so we did everything freehand. And so we relied heavily on our knowledge of the anatomy. And I think over time, as new technology has populated the marketplace, the reliance on it has gone up, not necessarily in parallel, but it's gone up. And I think for the training programs, I think it's incumbent upon us to make sure that as we're taking people through, we don't rely ourselves on it, even though we may be able to do it freehand. We have to keep in mind that we are training generations and generations of surgeons moving forward. So I guess it's more incumbent upon us to make sure that the people we're putting through get training in both ways, and we challenge them to be able to do it, the freehand technique, which is to use AP and lateral X-ray after the screws are placed.
Sure. I'm with you. I really cringe at the total reliance on robotics and the video game approach to spine surgery. But by the same token, this is sobering. Again, I would assume we were much better than that. So thank you once again for a wonderful presentation.
Oh, no, thank you. It's interesting though, if you really think about it, we talk as surgeons, with the facet joint violations, 20 to 30 to 40%. But that really means, a large portion of patients that we're operating on, we're actually doing them a disservice. And so there's a fantastic opportunity for us to improve our own craft. And it's just really up to us, I think, to disseminate the message to make sure that the surgeons out there are at least recognizing this as a very bad complication. It doesn't rear its head immediately post-op. In fact, the patients oftentimes don't complain about it, at least in our study, until 2 years follow-up. But the reoperation rate 2 times normal, it's not good by any stretch of the imagination.
Sure.
Yeah, we do have a question from Dr. Malik. Would you like to ask that question, Dr. Malik, or would you like me to read your chat message?
Yeah, no, I can ask it.
Perfect.
I think, anyone can tackle it between the two of you. I have a 90-year-old who has a grade 1 spondy at L4-5, and she's very symptomatic. So my question was, in somebody, older, more leaning towards osteopenia, I'm still waiting to see her DEXA scan. Would this be indicated?
Well, that is always a tough one. All of these technologies, all of them depend on a certain stability of the bone screw interface, which mandates a certain amount of bone density. If this is a 90-year-old that is not osteoporotic, it really isn't osteopenic, then the answer is yes. But if you're osteoporotic, the answer is no. And at 90, I really worry that anything would really be indicated safely. You will have to take into consideration, trying to treat the osteoporosis and osteopenia ahead of time, maintaining that treatment throughout the surgery, which I find that many times in doing so, you end up with a very robust bone amount of deposition around the instrumentation. But even then, the risk of failure of the device and the bone screw interface is going to be large, and that really has to be taken into consideration for your risk-benefit considerations.
Thank you. And my other question was, how do you decide between using either a single implant or two implants? Or is that dependent on the anatomy as you encounter it when you go in?
Yeah, and that's the same thing. It boils down to the anatomy, the overall stability, and quite frankly, the pathology. For example, a massive disc herniation on one side where the annulus is completely destroyed, or excessive exposure is going to be needed on that side, but the other side is totally asymptomatic and totally normal. I would tend to, in an otherwise stable situation, that would be for me a case of the unilateral approach. I've always wished that when I do these massive herniations through a little laminotomy, that I didn't have to do bilateral screws and a total laminectomy to get implants in. And this implant actually allows that opportunity. And so careful selection of the patients, the massive disc herniation, unilateral pathology in an otherwise normal, stable spine, for me was one of the primary, would be a great indication for a unilateral approach. Anytime you can spare native anatomy and get the job done and maintain anterior column support, to me is a bonus.
Thank you.
Well, thank you for your question. It's very, very informative.
Yeah, this is John Kessler. I'm with Wenzel Spine. But this question, I guess, Dr. Mroz, I was curious as to what your thoughts were on global sagittal alignment, and whether or not there's an overemphasis on it, because it seems like that's the main thing people talk about when they talk about avoiding adjacent segment disease. It seems like Facet violation plays a big role in that. And do you feel like there's an overemphasis in really, correcting that alignment in even like 1 and 2 level pathologies?
Yeah, so it depends, in my opinion, which level you're working at. Obviously, if you're at the lower lumbar spine, each one of those segments actually contributes a fair amount to the overall global sagittal alignment. As it pertains to facet joint violations, I do think it probably has some bearing. It just hasn't been defined accurately in the literature. And what I mean by that, if you have a patient who is globally sagittally positive, that would mean that if you violate a facet joint at the cranial infused level, it's likely that they could become more symptomatic. Now, that's just maybe my intuition speaking. It's not been borne out in any meaningful literature, but no, I do think it has some bearing with regard to how patients would do after a facet joint violation. It depends on how you're loading the joint. On the other hand, if you have a patient who's got negative sagittal balance and their head's a little bit posterior to the pelvis, that would imply that they're loading their facet joints a little bit more. And then so if there's a facet screw there's a screw going through the facet joint, they could be more painful than having positive. So I think it matters. Intuitively, I think it does, but I don't have literature to back me up on it.
I would just like to comment that thank you for the presentation. I think I had 2 patients that in my mind I was going to do a 2-level 360. And both of them are on the younger side. Both of them are, one's in the late 40s, early 50s, the other one in early 50s. And I think I may choose to do this rather because the hospital I'm going to do them in, I do not have a robot or stereotactic navigation or an O-arm. And so my risk with, our usual techniques of doing them minimally invasively, probably there is going to be a facet joint violation, which, I think is unrecognized in a lot of cases. So thank you.
The question is regarding training and more movement, especially into the future, potentially for cost savings measures, as we see appropriate patients, so slightly healthier, younger, all of that, moving into possibly an ASC setting. What do you think the ramifications are? Like, say independent of what technology you might want to use for an implant or for posterior stabilization, what could the implications be in that capacity where you're going to see ASCs trying to avoid having big capital equipment, such as navigation capabilities or robotics?
I can comment on that. We are one of those institutions that, particularly during the pandemic, we've cut discretionary spending and capital investments substantially. And so that is a real concern in terms of how the spine community adopts robotic technology, CT-based navigation, virtual reality technology. And so I think that remains to be seen. Will it be a driver to adopt an entirely, non-navigation approach to care? Potentially. But I can tell you just from my own experience, we've tried to deploy a variety of different capital investments to a lot of our different hospitals that we own. And it is a challenge current day, but it was a challenge pre-pandemic as well. So your point's apropos. I just don't know exactly how it's going to play out, because ultimately, we're going to have to make sure that whatever care that we render is still evidence-based. And so, I think it's going to be a sort of a tug of war between the clinicians and the hospital administrators in terms of what we get and what we don't.
Well, I will have to place bold quotes around the evidence-based. Everyone has their intuition. I currently am in an ASC situation where the whole concept of an unsupported interbody threaded cage brings back the fears of the BAK and the cage rage. And as such, there has to be evidence that will counteract that. The data that was shown this evening is a step in the right direction. But with that and adoption and acceptance of the safety and efficacy of the technology, I think that the writing is on the wall. This offers a more economical solution, and if the clinical outcomes warranted, the faster approach to less invasiveness, the minimally invasiveness, maintaining absolute integrity of all the other structures, save for the laminotomy defect, really lends this to play a major role going forward as the index procedure. And so I think that the key is going to be generating the evidence to demonstrate the appropriateness and safety and efficacy to get the guidelines for the appropriate patient for this to avoid overutilization or misutilization, placing the technology in harm's way.
Thank you.
Okay, well, thanks again, Dr. Davis, Dr. Mroz, appreciate it. Kim, thank you for all your work and effort, and appreciate everybody's time and attention. We'll look forward to our next event.